A'udhu billahi minash shaitanir rajim. Bismillahir Rahmanir Rahim. Assalamu alaikum. This afternoon, inshallah, first I would welcome all of you who've joined us this afternoon to learn more about a very important subject. When we start talking about being advocates for social justice, one critical need is in the area of healthcare, particularly as the delivery of healthcare services impact the African American community. Biased policies and practices are deeply rooted in our healthcare system, whether they're based on gender, race, or culture. And our healthcare system has been shaped for generations, and it will take time and effort to achieve equitable quality healthcare. To achieve equitable healthcare, these biases and practices must be identified, acknowledged by those who enable them. With this identification and acknowledgement, the need for change processes can be implemented designed to root out disparate discriminatory practices in the delivery of healthcare. This afternoon, we are fortunate to assemble a panel of experts in the health field or the health delivery field, and particularly as it impacts the African American community. They are here to start to answer some of the questions that we have. I mean, too often we use the terminology disparities and equities and without really understanding the full meaning or the impact, the import of what those words mean and how does it actually reflect and the delivery of healthcare in various communities of color, particularly the African American community. This afternoon, these panelists, we have assembled three. We have Dr. Munira A. Curtis. She is the medical director of the Optum Healthcare System. We have Dr. Constance Shabazz, who is the founder and board member of the Salam Community Wellness Center in the Inglewood neighborhood right here in Chicago. And we also have Rilwan Martin, the executive director of Masjid Al Farooq, as a representative of the Al Farooq Community Health Center on the south side of Chicago. Each will bring their unique perspective on the delivery of healthcare in the African American community, how it is reflected, and guide us in a discussion how we can collaborate and improve the delivery of healthcare across the African American community and throughout all communities of color. So with that background for each of us, we would ask that you pay attention and we're going to encourage your questions and we're going to encourage you to come up with any suggestions you may have how you can work with these advocates for healthcare in the African American community to improve the quality and delivery of healthcare services there. So with that, inshallah, let me now bring on the first panelist, Dr. Munira A. Curtis. Dr. Curtis, the platform is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Munira Curtis. I am currently a medical director in a larger structure by a company named Optum. So actually it's just a smaller piece of a larger pie. A little bit about my background. I did my undergraduate at University of Michigan, my medical school training at Wayne State University School of Medicine, and then I did my residency at Children's Hospital of Michigan in pediatrics. I was the chief pediatric resident, and thereafter I started on my journey as a pediatric hospitalist for 9 years, primarily in the academic settings, working with residents and medical students. About 10 years ago, I moved from clinical practice to non-clinical practice, and for the past 7.5 years I've been with the United Health Group, Optum United Healthcare, as a medical director. And currently, I am working with the appeals team in clinical validation. So with that being said, I would like to begin my presentation. Okay, this might have run over. So today we're going to be talking about healthcare inequities. The title of the overall arching presentation for all three of us is Understanding Quality Healthcare and Its Unequal Delivery to African Americans and People of Color. I have a few disclaimers. The opinions expressed in this presentation and on the following slides are solely those of my own and not those of Optum or its affiliates. I have no financial interest to disclose, and no compensation has been awarded to me as a result of this talk. So the World Healthcare Organization has described quality of healthcare as the degree to which health services for individuals and populations increase the likelihood of desired outcomes. It is described as care that should be effective, safe, people-centered, timely, equitable, integrated, and efficient. And then I call your attention to the definition of what is equitable, what is the thrust of equitable, and that is providing care that does not vary in quality on account of gender, ethnicity, geographic location, and socioeconomic status. And one of the things I want you to note is that it actually says ethnicity, and we'll come back to that point in a moment. So now we want to talk about this idea of equitable healthcare. So first we need to understand a few definitions. First, the definition is health disparity. This is a difference in health outcomes between different population groups. The CDC describes this as preventable differences in the burden of disease, injury, violence, or in opportunities to achieve optimal health experienced by socially disadvantaged racial, ethnic, and other population groups and communities. And these health disparities are driven by underlying social and economic inequities that are rooted in racism. So a health disparity is a difference. It's a difference in health outcomes between different groups of people. So why are there health disparities? Well, we kind of alluded to it in our definition of the disparity. So health inequities are systematic differences that are the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. So first we have this disparity, this difference in outcomes that we see, and it's driven by these differences, these unjust social and economic policies and practices, and create barriers and change these outcomes of different people. So in order to kind of say, well, how does this affect us personally on the ground in the community? We first need to understand, we're going to take a small part of that. And as you see, there are various ways that people can be affected. You notice in the definition of health disparity, it talks about socially disadvantaged, it talks about racial, ethnic, it talks about population groups, it talks about communities. Today, we're going to focus on how it affects African Americans, how it affects Black people. And in that way, we're going to have to take a look at race. Race in medicine, and what does it mean? So the first most important thing that actually I myself became more aware of, even within the recent year or two, is that race is a social construct. And now we're going to explore what that means, how we get there in a moment. But let's explore a few other things as far as how it actually impacts medicine. So in a special meeting of the American Medical Association House of Delegates towards the end of 2020, the AMA came out with two policies that literally said they recognize race as a social construct and not a biological construct. And again, we're talking about medicine, and this is why this is important. The policy stated that they recognize that race is different from ethnicity, genetic ancestry, or biology, and aims to end this misinterpretation. It recognizes that there is a false conflation of race with inherent biological or genetic traits, and it recognizes that this conflation exacerbates exacerbates existing health inequities. So this is how we're kind of getting to this race and inequities. And it supports the ending to the practice of using race as a proxy for biology in medical education, research, and clinical practice. And it recommends that clinicians and researchers focus on genetics and biology, the experience of racism, and social determinants of health when describing risk factors for disease. So now we need to understand, now we have this thought. We understand that there are differences in healthcare with regards to disparities. They're caused by health inequities. And then we're taking a piece of it and we're focusing on race because we're dealing with, again, the people of color, the Black experience in healthcare today. And now we're coming to this piece, race is not a social construct and it needs to be separated from biology. How in medicine, that's what we aim to treat. So we need to understand, well, how did it become a social construct and why does it influence us as people in healthcare? Prior to the mid-17th century, there existed freed slaves, freed Africans, who actually, after a period of servitude, were able to actually have freedom. There was recognized that Africans actually were skilled in areas such as blacksmith, smelting, brickmaking, and many other areas. In addition, the word race itself previously was used to mean type or sort or things of that sort. So that's very important. And finally, also, there were Irish and Indian slaves or Native American slaves, as well as African slaves. And the other thing to remember is prior to the 17th century, again, in the United States, in the Americas, the social position of Africans was fluid and not related to an ideology of inequality or inferiority prior to mid-17th century. Then we have colonies that actually began to enact laws. So beginning between 1660 and 1690, the Virginia colony passed some of the first laws and practices that actually provided preferential treatment to freed servants of European origin. It actually had these laws that bound Africans and their children permanently as servants and then as slaves. And then it prohibited voting and other civil rights. Then it progressed into a more sophisticated form. Now, the reason you might say, well, why are we passing these laws and why are we doing these practices? Well, the reason is because of wealth. Ultimately, the number of Irish and Native American Indian slaves decreased for a number of reasons. And Africans became the preferred slave. And as a result, they found justifications to continue enslavement. Slavery brought wealth. So the steps in which they went to codify African slavery in the Americas was to dehumanize Africans in order to emphasize them first as property, using Christianity to say that African souls needed to be saved, otherwise they were heathen. And then finally, as the years progress, you have the political and intellectual justification of Africans being naturally inferior and best suited for slavery. And also the trope that God made men unequal. And then the next level, years later, physical differences of Blacks and Indians were now becoming a symbol or marker of status. And now you have race being used as a ranking and inequality of Black and Indians. So this is how we get to this idea of race being the color that we see. So again, I just want to remind us, race is a social construct, and it has its roots in justification for slavery of a particular people. You might say, why were Africans singled out? Was it some sort of deficiency? When actually it's not. The reason why the Africans were chosen as preferred slaves was because of, again, of their skills, their knowledge of agriculture during that time. The fact that also, geographically, they had nowhere to turn to. You had Native Americans actually that could go back to some escape and go to other tribes. The Irish at the time were considered unruly or violent, and also could band with Spanish and French Catholics, once they almost had another group to kind of go to. But the African slaves were isolated geographically, and they had skills and knowledge, and also weren't as susceptible to some of the diseases that some of the other ethnic group of slaves and servants were susceptible to. So then how does this race as a social construct, how does it come to us? Well, in about a year ago, the New England Journal of Medicine described how structural racism works, and it described racist policies as a root cause of U.S. racial health inequities. It talks about structural racism, or sometimes called institutional racism. And what it means is racism that is held by individuals, that is produced by laws and rules and practices, that is implemented by various levels of government, and then embedded into cultural and societal norms and in the economic system. So at every level of being, individual, group, society, economic, law, it's embedded. And that's what structural racism. And this article very nicely talks about how this affects our health. Specifically, naming 3 interrelated domains that affect population and individual health: redlining and residential racial segregation, mass incarceration and police violence, and unequal medical care. Specifically, residential racial segregation remains a powerful predictor of Black disadvantage. So I want to take a little bit of step back. What does that mean, this redlining? Well, redlining is this. After the Depression, the government created a federal agency in order to guide mortgage worthiness in over 200 cities in the United States. What they did, this was in order to increase home ownership after the Great Depression. And this agency literally drew red lines around areas in which there were large aggregates of Black people. And they flagged them as hazardous investments. And as a result, they would not receive any of these government loans. As a result of not receiving government loans for these homes, then you have a decrease in Black ownership, home ownership. You have a decrease in intergenerational wealth and passing on, and then also an undervaluing of Black real estate, on top of the violent practices that were occurring, in which you literally did have white mobs going into Black neighborhoods and literally burning them down or killing many Black people. And this is the residential racial segregation, because to this day, these areas that were redlined have persisted in these geographical areas. In these areas that were previously redlined, that were once redlined, they have a higher incidence of preterm birth, higher incidence of cancer, tuberculosis, maternal depression, and mental health issues. Then we come to this idea of scientific racism. Scientific racism has some basis as far as eugenics movements, in which they emphasize Nordic superiority and the need to breed superior races. Specifically, you have scientists and researchers in England, in the Americas, joining this movement, some of them with medical backgrounds, some of them with more of a political wealth background, but still emphasizing this and beginning to write texts and other documents that became mainstream. You have Samuel Morton, who had a large collection of skulls and did a lot of anthropomorphic measurements of people of many races. And he developed an intellectual hierarchy based on skull size that said, placed whites at the top and Blacks at the bottom. You have James Marion Sims, who is celebrated as a father of American gynecology, who performed repeated gynecological surgeries on slaves without anesthesia, but used anesthesia on white women, citing the belief that Blacks did not feel pain in the same way as whites. One of the things I see when we look at history sometimes, particularly when it applies to racism, is we say, that was then. Yet in 2016, in a study of racial attitudes in medical students and residents, half of white medical students and residents had beliefs associated with assessments of Black patients' pain being less severe than that of white patients, of which there is no biological justification. So where are we now? Well, unfortunately, we still have these unfounded views of race of a people that cause disease, and this does affect treatment on an individual level. You have systematic disinvestment in Black neighborhoods that leave healthcare facilities with less resources and fewer clinicians. And then, critically, you have an acceptance of inequitable treatment as normal, as expected, that Black people are intrinsically disease-prone and not deserving of high-quality care. Well, where can we see this? In a study that came out in July of 2021, funded by the Robert Fund from Robert Wood Johnson Foundation, the question was, do Black and white patients experience similar rates of adverse safety events at the same hospital? They looked at data from inpatient data from 26 states in 2017 for the Agency for Healthcare Research and Quality in about 2,400 hospitals, and they found in 6 out of the 11 indicators, Black adult patients experienced significantly worse patient safety events compared to white adult patients of the same gender and treated in the same hospital. Racial disparities in patient safety occurred even when patients had similar types of insurance coverage, and Black patients experienced worse patient safety events in hospitals that serve more Black than white patients. I won't go into the details of the specific indicators that they looked at, but I wanted to bring this to our attention. The National Institute of Children's Health Quality, they have three very commonly known, unfortunately, statistics. That infant mortality rates for America's Black babies are more than twice the rate of white babies. Black babies are more than 3 times as likely to die from complications related to low birth weight as compared to white babies in the U.S. And U.S. maternal mortality rates for Black women and birthing people are 3 to 4 times higher than rates for their white counterparts. Now, I want to take a little bit of a turn before I end. And I want to say, frequently when we look at this idea of institutional racism, we take away the personal responsibility, we take away the individual experience, and how a physician treats that patient and how it affects healthcare. And I want to say this. There was another study that looked at physician-patient racial concordance and disparities in birthing mortality for newborns, meaning they looked at 1.8 million births in Florida between the time of 1992 to 2015. And what they found was there was significant improvement in mortality, death rate of Black newborns when the Black newborns were cared for by Black physicians. It made that much of a difference. The Black-white newborn mortality gap is smaller when Black doctors provide care for Black newborns than when white doctors do. And then finally, there's another report that came out of the American Journal of Kidney Diseases. And the special report titled Reassessing the Inclusion of Race in Diagnosing Kidney Diseases, an interim report from the National Kidney Foundation Association American Society of Nephrology Task Force, stated, African Americans with advanced kidney disease are younger, with an incidence of kidney failure nearly 3 times that of their non-Hispanic white counterparts. Such disparities go beyond the burden of kidney diseases and extend into differences in kidney disease treatment. And then finally, as cited by Dr. Creer Perry, who does a lot of work in health inequities, has spoken in front of the United Nations Office of Human Rights, and worked with ACOG and the Robert Wood Johnson Foundation, has said, race is not a factor for illness and death, but racism, bias, and discrimination definitely are. And I thank you very much for allowing me this time to speak. And I emphasize that I am providing this. I want to just say this. The reason why I was interested in this topic was not necessarily as an expert in this topic, but as someone, as a physician and a Black person who actually has had some personal experience that brought some of these things to light. And I needed to know why. Why was I and my family being treated this way? And so I delved a little further, and this has actually elucidated a lot of information for me personally also.
Wa alaikum salam. Thank you, Dr. Curtis. That definitely, inshallah, gives a clear perspective of the root and the history and the development of racism and disparities, and the contemporary evidence that she was able to share, that this isn't a problem that's being exaggerated or an overstatement, or it's something that used to be. It is here, It's among us. Even her own personal experiences will testify that racism, bias remains a problem in the delivery of healthcare for African Americans. Thank you very much. At this point in time, we would like to turn the platform over to Dr. Constance Shabazz, as I said, the founder and director of the Salam Community Wellness Center. Dr. Shabazz.
Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. And I want to thank Dr. Munira Curtis for her very important, informative presentation, defining what health disparities mean, as well as healthcare inequities and the impact that it has on African Americans. A little background about myself, as Brother Abdullah Mitchell mentioned, I'm the CEO and one of the founders of the Salam Community Wellness Center, located in the Woodlawn community on Chicago's South Side. I have over 45 years of history working in the healthcare field. I consider myself a health care justice advocate, advocating for equitable healthcare for all. I have an educational background of being a graduate of Southern Illinois University School of Medicine. I completed my residency in internal medicine at St. Joseph Hospital in Chicago. I have a master's in public health and a master's in business administration from St. Xavier University here in Chicago, as well as I have a master's in public administration from Harvard University's John F. Kennedy School of Government. So it's a pleasure to have this opportunity to speak on this very important topic. I'm going to attempt to pick up where Dr. Curtis just left off and actually share with you a little quiz that I came up with. And this is really based on a lot of the assumptions that are made about the socioeconomic conditions of African Americans and the healthcare conditions. And so the reason why I came up with this quiz is because many of the policies that we see that are supposed to address these inequities, they're based on assumptions that many legislators and other people who are in power make based on things that they think are going on or explanations as to why African Americans are in the condition that they are, both socioeconomically as well as healthcare. So I'm going to go through a few of them, and these are true or false questions. In general, the lifespan of African Americans is equal to that of white Americans, and that's false. Actually, nationally, it's about 10 years different, and depending upon where you are in Chicago, when we looked at different neighborhoods, predominantly white neighborhoods, and on the north side of Chicago, and predominantly African American neighborhoods on the south, that difference even goes up even higher. We're in the neighborhood of 15 years difference. The next one, in general, African American health outcomes are worse than white Americans, and that is absolutely true. We are at the top of the rankings for poor outcomes for diabetes, hypertension, obesity, and a number of other chronic diseases. These outcomes are due to genetic differences between African American and white American. And as Dr. Curtis mentioned, there really are very few genetic differences that make a difference in terms of our health outcomes. So that is false. These outcomes are due to chosen lifestyles of African Americans. In other words, there's this assumption that the African American love to eat unhealthy foods or engage in unhealthy social behaviors, tobacco use, alcohol use, illicit drug use. And the last one, the illicit drug use, there are studies that say that basically the illicit drug use is no different among different ethnic groups. But we know that the carceral system has punished African Americans to a greater extent than other ethnic or so-called racial groups. African Americans tend to innately be more violent than other ethnic groups. And even though those of us who are in Chicago and who have the unfortunate exposure to a lot of violence in African American communities, this does not come out of it being something innate or genetic to African Americans. This is as a result of systemic racism and decades and actually centuries worth of racial animus and racial disparities within these communities. And this is an outgrowth of that, unfortunately. Another assumption is that there's no relationship between poverty and poor health outcomes. Well, obviously there are, because when we look at health outcomes, we're also looking at how our society actually helps to support the healthcare system. Many of our taxes, which come out of the economics in our community, help to fund our healthcare systems. Taxes are used to determine the number of hospitals. They help to support even the community health centers, and they provide support to educational institutions. And out of those educational institutions comes the workforce that becomes the physicians, the nurses, the doctors, the other practitioners. So poverty has an inextricable link. Housing desegregation has allowed most African-American equal access to affordable housing and home ownership. And that's definitely false. The sister talked about the redlining. And again, back to what I just said, home ownership is tantamount to wealth building, and that wealth building helps to support financially all the things that a community needs. African Americans pay lower taxes and have access to capital for wealth building at the same level as white Americans. Certainly we know that that's not true, that even though African Americans as a group collectively tend to have lower incomes, we are, and I include myself, are taxed at a higher rate in terms of proportionality, in terms of how much of that actually gets paid as taxes. Where you find, like we found with COVID, with the PPP loans, that there were many wealthy individuals and corporations that paid, they had to pay no tax at all, because they had the advantage of being able to apply for larger, I would say discounts, if you will, that lowered their actual tax impact. Whereas those individuals of low income don't have those perks. The last one here is predominantly African-American communities have the same access to resources that non-African communities have, such as the high-performing schools, the safe water, decent transportation, access to affordable, healthy foods, and the like. And we know that that is false. And that all has an impact on our outcomes in our communities. So as you can see, there's so many things that factor into why we have the disparities that result from the inequities in the African-American communities. So part of the next part of my presentation is going to talk about, well, what kind of models of change will address those things. I and Brother Rawan, who is representing Masjid Al Farooq, are going to talk about models of change that we think will help to improve and lessen that gap of healthcare inequity. So the Salam Community Wellness Center is located on 613 East 67th Street in Chicago's Woodlawn community. This is just a picture of the front of our beautiful building that was rehabbed. And I'll tell you a little bit how that happened. This is a whole complex. Not only do we have the wellness center there, but soon opening next door to us is going to be a healthy restaurant to help give the members of the community options, healthy food options. This is a picture of our waiting room area, and to the left is our wonderful medical assistant, to the right is our medical director and one of our earlier patients. We just opened up our facility for patients on January 10th of this year. So to give you a little background, back in 2020, Salam Community Wellness Center came into existence in the Woodlawn community as a result of the impact that COVID-19 pandemic had on Black and Brown communities. It came out of the recognition that these outcomes, the high rates of infections as well as deaths, was as a result of unaddressed and underaddressed chronic health conditions such as hypertension, diabetes, lung disease, kidney disease, obesity, and the like, and social determinants of health that had not been addressed appropriately. That includes things as poor housing, transportation, quality education, food insecurity, and our work environments. And the reason why I added that is because many of individuals were in low-income communities are considered what we now, the common term, essential, are considered to be essential workers, and they were at the front lines, public facing oftentimes, bus drivers or working in grocery stores at greater rates of exposure, or working in meat packing plants where people had to work close together and there were not the kinds of safety precautions that were taken. So those two things together had to be married to really look at why we had the impact that we did. Let's talk a little bit about our catchment area. Who are we trying to serve? Well, there are over 900,000 residents on the south side of Chicago. In the Woodlawn community alone, when we started looking at the statistics before COVID, some 33% of its residents were below the federal poverty level. There are only 9 hospitals, and I apologize if I'm missing one, but there are only really 9 hospitals that serve this population, but they're not evenly distributed throughout the area, which means that for some people, it's a major barrier to get back and forth to a hospital, not just for emergency services, for inpatient services. Many of these hospitals also provide, primary care services and specialty services. So therefore, we're really in what I call a healthcare desert. Prior to COVID-19, there was a planned closure of 4 safety net hospitals, not 1, not 2, not 3, but 4, in an already healthcare desert. And so therefore, we noted that there was a decrease in some of the services that these hospitals were providing. An example of St. Bernard's had discontinued their obstetrical services. And for those of you aware of this, Mercy Hospital was on the verge of closure. And alhamdulillah, there was a Muslim group that came in and purchased the hospital. But even with that, to this day, they're still in the process of rebuilding and reconstituting the services that were lost over time. And the last bullet point here is the corporatization of healthcare. And what do we mean by that? That most of the healthcare practitioners on the South Side are employees of large medical systems. So essentially, they have no control over where they practice. So as much as many of us as practitioners who went into healthcare to return to our communities to provide the much needed healthcare, we don't have a choice. If our boss says, no, you have to provide care someplace else, where typically where there's a larger number of people who are well insured. There are also a number of federally qualified healthcare centers, and I spent most of my professional life working with these centers. And that's great that they are available. That is the mandate that they have, being a federally qualified healthcare center to serve low-income, underinsured, and uninsured communities. But unfortunately, they're not always marketed well and not always as accessible to the needs of the community. Let me give you a personal experience. Several months ago, as I was traveling back and forth from Chicago and elsewhere, when I came back to Chicago, I had some symptoms that I suspected might have been COVID. So I looked up the names of the federally qualified healthcare centers that were close to my residence. And I found one that actually had 3 locations. Unfortunately, when I called, I found out that not one of those locations offered a COVID test. And that in order for me to get the test from that health center network, I had to travel 5 miles out of the way to go get a test, only to find out also that they only offered the test on a 3-hour period on 1 or 2 days a week. That is not accessibility. Also, the South Side is a federally designated health profession shortage area and a medically underserved area. By that, it means that there are not enough healthcare professionals provide the breadth of services needed by the residents, as well as there are not enough other medical services available for that size population and the complexity of their needs. Lack of emphasis on cultural competency and its impact of health outcomes. This is a huge issue. The University of Illinois put out a very interesting report last year, early 2021, and they interviewed a number of individuals who indicated that the reason why they stopped going to their primary care physicians because they felt that their primary physicians oftentimes were out of touch with their reality. They would oftentimes have a provider say to them, well, to improve your diabetes, to improve your hypertension, to lose weight, you need to eat more fresh fruits and vegetables, and not even recognizing the fact that these individuals, for the most part, lived in food deserts. And lack of access to complementary health care. Oftentimes when we think of complementary health care, it can be acupuncture, Tai Chi, yoga, massage, whatever. We think of those are things that happen in spas. But no, complementary health care, and this has been noted from some reports, that probably 2/3 to 3/4 of the world population uses on a regular basis what we would consider complementary healthcare. And so this is very important for us to understand that this is really part of a real holistic healthcare system. But many people who live in low income communities lack the access to that, even though they would desire to be able to access these kinds of therapies as a part of, and in replacement oftentimes for some of the more toxic treatments that we have. And we won't get into that as for perhaps another presentation. So our proposition with the Salam Community Wellness Center is to build a new system of healthcare. And I put new in parentheses because, or in quotes rather, because it's not the modalities that we're using are new, but how we're using them. And what we have designed is an integrative model, using both the best of Western medicine and the best of non-Western modalities in a culturally competent manner. So we provide our care, our primary care, addiction prevention and treatment, mental health, our nutrition, focusing in on trying to eliminate food deserts in the community, creating a holistic urban farm, integrating the complementary healthcare services like the deep breathing, meditation, sound therapy, traditional Chinese medicine, acupuncture, and the list goes on, into a comprehensive model. And that we marry that with the critical need to address social determinants of health, creating a holistic model that addresses what I call some of the critical elements for success, because we can do a great job providing people with the physical health care and the mental health care. But unless we understand and help to address some of those other underlying issues, those what we call competing priorities that people have. In other words, their housing situation, how they're going to have adequate food, transportation, having work that income that helps them to survive and thrive, then that's going to undermine everything that we're trying to do with this holistic medical model. So our goal and what we're doing right now is building a case and care management program. A case management program is really, I would say, more the kind of umbrella type of care program that looks at the housing and the transportation, child care, daycare kind of things, or elder care issues. But the care management is really typically focused more towards disease management. So what does that person need who's a diabetic? They may need help in finding the adequate care for podiatry care, for foot wound care, for optometrists, transportation just back and forth to specialists. So we want to include in this model community health workers, and these are individuals who can go into the home and work with residents in the community and find out what are all the things they need, both on the medical side as well as the social determinants of health side. We are working to and have been very successful in developing collaborations with other organizations, be it healthcare, governmental, faith-based, social service, and educational, because they all play a role in the health of a community. And we're in the process of designing a referral system that connects residents with resources and the necessary follow-up and support that they need. Because a lot of times, and this comes really out of my experience with working with community health centers, they're very big on the health centers having collaborations with other partners. And the reason being is that by having a referral system that connects people to these resources, we as an agency, as a vehicle, can help to eliminate what oftentimes happens. We know about a social service agency down the street, but when we give that information to the patient, that patient may not follow through out of fear because they're used to agencies telling them, I can't help you, no, I can't help you. I can't do anything for you. And by us being the broker on their behalf, that the advocate on behalf, we can help to bridge that gap so they not only are referred to the right agency, but they get the services that they needed through the agencies. And last but not least in this model is a cultural competent healthcare. Respect is the key. Our motto is that we listen to our patient, and we see this as true primary care, because unless you know what the patient, what they're going through, what their concerns are, and that's the model in which the health system is supposed to be using anyway. We use what's called the SOAP format when we do our medical documentation. And the first thing is subjective. What is it that person, what is their complaint? What is it that they're challenged with? And we put that as a priority for us. We do not impose any time limits on our visits. Most of our visits are 1 hour minimum. If it goes beyond that, we're perfectly fine, because basically it is the patient who should be the driver, not us. We're addressing the mind, body, and the soul. We're addressing those social determinants of health. And what we're doing, and I say this all the time to my team and others, healthcare, with few exceptions, is not about what you do to the patient. It's not about, the medication that you write a prescription for. It's not about, the surgical intervention or whatever interventions we do. Most of what we do is educating and offering patients options and using a multi-prong approach, as I mentioned, the best of the West, the best of the non-West. We have internal partnerships that we are building on. We're bringing in other providers, primary and specialists, including our complementary therapies. And we have very important external partnerships that we are building on. Currently, we have one with St. Bernard Hospital for the provision of our laboratory services, but we're also going to be talking to them about, radiological services as well as specialty, and they even have dental services. We've been in discussion with Chicago Insight Medical, which is the name of the new name of Mercy Hospital, about actually introducing to their staff our integrative model for addictions and mental health treatment. And in turn, they're talking about the possibility of placing mental health providers at our location, because we want to make sure as much as possible that we are a one-stop shop and that we are bringing to the community resources that have long left the community. We also looking at primary and specialty care practices, working with them, free and charitable ones, federally qualified healthcare centers, and other healthcare or health-oriented organizations. So just briefly, we have entered into collaborations. The University of Chicago is helping us out with our financial and fundraising model. Governor State, we have an affiliation with their community health department for interns. Dominican University, they're going to be placing physician assistant students at our site. Chicago State, we have an agreement for them to place social work interns at our site. And University of Illinois Urbana-Champaign, that's a new affiliation, and we're working with a Dr. Ruby Mendenhall, who has a fantastic, I call it a health hub program that she's gotten funded through the MacArthur Foundation. Community-based, a number of organizations in the Woodlawn community that are providing similar services. And of course, our faith-based organizations, CIOGC, Zakat International, IRUSA, and Masjid Al-Taqwa. So how do we support this? No margin, no mission. And so we have to have support to do this. So we do it largely through, most of our fundraising rather has been done through individual donations, a lot of crowdfunding. We had a grant award from one foundation. We received the Critics' Choice Award through CIOGC. And I had to emphasize, we have not received a penny in terms of government grants or funding. I'm gonna say it again, not a penny of government grants or funding from the government. We've received in-kind donations. Our generous private donor who actually owns the building put over $800,000 worth of his own capital into the renovation of a 3,300 square foot facility, and we have another 1,500 square feet contiguous to that particular space that we're going to, inshallah, build into. We received in-kind in terms of our IT infrastructure and computers. We've received in-kind donations, medical equipment, supplies, furniture, and of course, we have the volunteerism from our volunteer team and board of directors. So our current and future financial model is sustaining donations, which are really critical, crowdfunding, flat fee rates and discount payments, insurance reimbursements. We're in the process of enrolling with most of the insurance companies that we anticipate our patients will be presenting with. We're going after a number of grants because we're looking not just our global program, but we have two other programs we need funding for. One that is a violence prevention program, as well as one that addresses addiction. And eventually, inshallah, we hope to become a federally qualified healthcare center, either a lookalike center, which would allow us to be able to build Medicaid and Medicare and be reimbursed at an enhanced rate, or a FQHC grantee, which would allow us, in addition to those other things, funding. And so what role can you play? Please consider becoming a sustaining donor. An example of how the impact your money would make. $120 a month would allow us to provide 3 visits to low-income uninsured patients. Your money is going to help us to maintain salaries, hire new staff, cover our rent costs, utilities, purchase computers, more medical supplies, equipment, and furniture, and our proposed build out, and our proposed Paradise Garden, or our urban farm. So other ways that you can help: volunteerism, professional services, non-professional services, sponsorship. If you have a business that you would like to us to be able to promote as part of some event or some kind of workshop or webinar that we would do, educating the community. All of those things are ways to make this model successful. So this is our contact information, but I just want to share with you that although I said that this is a case model, this is a model that is still in its evolutionary phase. But so far, with the patients that we started seeing on January of 10, the response has been overwhelmingly positive. And so we pray, Allah, that you will join us in our continued effort to close the gap of health inequities in our community. Thank you. May Allah bless each and every one of us for our service to those in need. Assalamu alaikum.
Wa alaikum salam. Thank you, Dr. Shabazz. I mean, you gave a pointed insight in how we as a community can respond and begin to close the gaps in providing quality health care in the African-American community. And at this time, I would like to quickly turn over to Rilwan Martins. This is another example within the African-American community, or particularly the Muslim African-American community, that is providing healthcare services to those in need on the south side of Chicago. Rilwan Martins is the executive director of Masjid Al Farooq. Rilwan, the platform's yours.
Thank you. Assalamu alaikum.
Wa alaikum salam. And I think Sana's going to get your thing.
Mike, you're not highlighting this, the Wajahat person. Okay.
All right, while she's getting that up, clearly something, there we go.
Okay. Bismillah ar-Rahman ar-Rahim. Salatu wassalamu ala Rasulillah. Amma ba'd. Thank you so much, Dr. Shabazz and Dr. Curtis, for laying the foundation for myself to follow, and for CIOGC also to put this platform together. Well, the topic is health inequality, and we know that Masjid Al Farooq is located in the inner city of Chicago on the south side. Next slide, please. The community demographic is 45% African American. We have 40% Africans and 15% Asian and Europeans that don't attend Masjid Al Farooq on a daily basis. And we have a congregation of about 500 to 600 during Jumu'ah service on every Friday. So next slide, please. Now, when it comes to health care challenges in our community, we've seen a variety of challenges in our community. One of them being that navigating the healthcare system. In order to navigate the healthcare system, there is trust that needs to be built in. And that trust is what our community members do not have when going into the healthcare system. More oftentimes than none, it is too late by the time our community members get to go to a hospital. We don't have a primary care doctor that comes to us or we go to. The last resort for us is to go to ER. And when you get to ER, everything is a rush service. I'll give you a case in point. A brother, Brother Musa, who took his revert and stayed in the Masjid Al Farooq housing program, had diabetics, and we didn't know of his condition until it was a little too late. And by the time we took him to the hospital, they said his foot had to be amputated. And that happened, and we had to contact his family because we could not go inside because we're not his family member. Although we took him to the hospital, we have to find a way to get the nearest family to him to be by his side. And returning back to Masjid Al Farooq housing system, we didn't have the exact care for him, and nor did the hospital give any kind of directions and care for him. So it became a day-to-day thing where we have to keep calling the ambulance to come pick him up because of sudden conditions changing in him. Unfortunately, in a light when the brother passed away. This should not be happening, but it happens in our community more often than times. And we also have the hospital sometimes reach out to us, Trinity Hospital, Jackson Park, saying that, oh, they have a African person here that passed away and they have no relatives for them. So, but they think they are Muslim. Can we come and visit them and see if we can do the janazah on them? These are the things that should not be happening in America, but it is happening. And the access to basic need is not there for us. Immigration issue is a concern for most of our members because if you're undocumented and you go to the ER, you need to show ID, you need to show personal information, and more often than times, you don't have the right information in your hand. Cultural sensitivity. You go in, you're wearing a hijab or you're wearing a tobe, they look at you as a radical Muslim or other than anything else, and the attitude you get is a different attitude. You don't get the compassion as a human being from some of these hospitals. And that builds a lot. That's where the lack of trust comes in and the safety concern comes in, because when they see you, they patch you up and they say, go home. Going home, there's no follow-up. And that becomes an issue for us. Next slide, please. Al-Farooq community, go back one again. The healthcare clinic started back in January of 2020. And at nauseam, we have so many meetings, how to start this, how to go about this, where we get the budget for it, where we get the money for it. And of course, to some of the nurses that were on staff with us, talked about the medical malpractice lawsuits and stuff like that. And we debated ad nauseum. And at one point, CLGC stepped in December of last year and asked about what are we doing. And we mentioned what we're doing, and they brought Dr. Salu and all the doctors on board and say, look, just go ahead and do it. Don't worry about setting up the clinic. Just set it up and we'll support you all the way. Next slide, please. And from there, Dr. Salu and some friends gathered around the program at Masjid Al Farooq. You have the Chicago Muslim Medical Alliance, the Global ICNA Relief actually just joined us about a couple of months ago. And of course, CLGC has been there. And through all this, first starting in September, we've been able to acquire a certificate from the National Association of Free and Charitable Clinic, where it would allow us to get some assistance for some medical stuff that we need at the clinic. Next slide, please. As I said, right now, what we do at Masjid Al Farooq is we have the clinic happen once the first Friday of every Jumu'ah of every month, and it's from 2 to 5. What we do is a blood screening, sugar screening, physical consultations, and also we start to do the COVID testing, and we start to do the vaccination also, other than the general vaccination that we had. Back in 2009, we had access to a Dr. Shazir, who usually will come during the month of Ramadan. Once in the month of Ramadan, he will bring iftar for the community, and he will bring his sons, who are also physicians, and they will come and check our blood sugars. You can go to the next slide, please. They'll come and check our blood sugar right after iftar, and he will sit around and ask questions, and he was really accessible and gave us the confidence that we look forward to every Ramadan coming in and have a question. Now that is one time in a year that happens, and we feel so comfortable with him. Next slide, please. And building upon that was one of the nurses in the community, Sister Ganiat, had access to Walgreens, and Walgreens at that time was trying to do some community outreach, and she was able to set up flu shot annually for the community. And once every the season of the flu season, we have the community come out and get the flu shots. Next slide, please. Now, CLGC had an interfaith COVID outreach program for vaccination, and through the clinic, we were able to galvanize the members of Masjid Al Farooq. And this is to show that if you have the right care and the right communication, you can get things done on the south side of Chicago. We made an email blast. If you can play each of the video one, yeah. So Brother Musa is one of the chairman. He spoke in Sonike to the community, and then we have the sister below spoke in French to the community, and we have the imam, the double side on the right side. He spoke in Bambara and then also in Arabic, and the imam in the middle was one of the first people to take the shots, and he boosted the confidence in the community, saying that the shot is okay to take. He spoke in English and also in his native tongue of Guinean. Next slide, please. And right now what we have is we have one of our classroom that we converted to the examination room, and they just have a desk and the chair. And the doctor sits on one side and the patient on one side. And you can see on the right side, there's a brother bringing his mother to translate for her to see the doctor. Normally you won't see this at the ER because nobody has time. Everything's rush, keep moving, turn the beds over. But here it is that they're able to actually spend some time, about 30 minutes to 45 minutes, to actually speak to the doctor and feel comfortable about it. Next slide, please. And this is one of the blood drives that we did, where we had to check the blood for blood sugar levels, and we have more practitioners now that are coming on board to help us out. We still need more. Next slide, please. And this is when we now do the COVID testing regularly now at the masjid. And we had a back to school COVID drive, which we took care from 80 families. And you can see the mother and the daughters and everybody coming out and doing a COVID test, which used to be like a taboo. Next slide, please. So the clinic started in September of last year, and to date, we see an average of 14 patients on that one Jumu'ah, and some actually had to leave because they had to go back to work. and they cannot wait. And they've been asking that we should have some extended time for the clinic. Due to the availability of volunteers, we cannot oblige at this moment, but we hope in the future we'll be able to do that. So in a matter of 6 months, we have about 84 patients on staff, and out of that 84, 6 is a recurring patients, and it's a ratio of 2 to 1 sisters to brother that attend the clinic, 2 physicians at each month, and 2 nurses at each month. Next slide, please. And all the volunteers. So what are our needs? Definitely, we need to convert our spaces so that it looks more like a clinical exam to help the doctors do their work efficiently. We need manpower. We need more doctors volunteering their time for us. And budget-wise, like Dr. Shabazz has put together a budget that is a model to follow that we can follow also at the clinic. And we need equipment and technological support. Next slide, please. Thank you so much, Jazakumullah khairan. This people that are we should thank for this event that happens at Masjid Al Farooq. And without them, we would not be able to set up the clinic or start the clinic. And I can't go down the list because due to time, but we should play the recording once again. You'll get the names. And we can go to the next slide. And we're thanking our sponsors for being here with us. Thank you so much. Jazakumullah khairan.
Assalamu alaikum. Thank you, Rowan. At this point, I mean, you've been provided three insights to healthcare, the problems and solutions. And also what's been shared with you, ways that you can help increase the impact and further bridge the gap in the quality of healthcare in the African-American community. So at this point in time, if there are any other questions, are there any questions that we could ask for? I mean, while we have these professionals at our disposal, if there's any questions you may have, you could put them in the chat. We will ask that of the panel. And if not, then we're going to, inshallah, we will turn over the program for closing remarks by the chairman of the Council of Islamic Organization, Brother Irshad Khan. And seeing none, Irshad, the platform is yours.
Thank you, Brother Abdullah Mitchell. Thank you, everyone, for joining today. This is one of my favorite topic, and as CIGC launching its 30th year anniversary, we were looking back to the 30 year of journey, and we reevaluate all the programs that we do and what are the programs that we're thinking that we should be focusing on going forward as a organization of 70 plus masajid, Islamic institution, and social organizations are part of the member of council. How are we providing that vision and the service to our members, and what are the value the CIGC is creating for our member and our partners? We're constantly evaluating that, and that's one of the reasons why I'm saying that this is one of my favorite topics, is how we can address the healthcare inequality, disparity, improving the quality of the healthcare, especially on our communities, which has, in my mind, has been neglected for many years. And it was really an eye-opening for me to hear from Dr. Munira Curtis about the facts and the reports that she presented, showing how disparity and in the healthcare system is, especially for the minorities and especially of race. And I'm really sensitive for that, and that's why I was looking forward for this presentation, and I was so delighted to hear from 3 different insights. One from the expert from medical field, creating and sharing the insight. Dr. Shabazz talking about how this wellness center of Salam can be a source And then the third, Brother Rahalwan from Masjid Al Farooq, I'm sorry if I'm not pronouncing your name right, is how that model can be implemented to execute all the learnings and then apply that in that forum. So the reason that I wanted to have this discussion, important discussion in this month especially, is to earmark our journey into how we can help our partners, how we can learn from these experts that we listened to their insight today, and how we as an organization council is taking this and applying this as not a one-off webinar, but also a program going forward in helping improving the healthcare quality in our African American communities. So that is why I'm so excited to have this program today. I'm delighted to have these enlightened panelists today. Thank you all for joining, Dr. Munera, Dr. Shabazz, and Brother Rahalwan, for providing your insight. And this is not one-off. This, inshallah, will be a program. The CIGC will be facilitating, collaborating, and making sure that our partners are well equipped with the information that we received today. And this is going to be an ongoing program that, inshallah, we will be hosting, learning more about these insights, and then how we can help the community in addressing these disparities and inequality in the healthcare system, especially to improve our healthcare, the quality. So stay tuned to CIGC for next of this webinar as a follow-up to make sure that we have a plan put in place. This was just to share the kickoff of this program in this month. And then inshallah, we will be coming back and looking at how in our framework or strategy plan of social justice, how we can address some of these healthcare, improving the healthcare quality. So again, thank you for all the panelists today for sharing your insight. And also want to thank you for joining today with us in this afternoon. And more to come on that. I'm really excited for today's talk, and then I'm really looking forward and more to come on that. So thank you again. Brother Michelle, I'm going to turn it over to you for the closing remarks.
Thank you. Assalamu alaikum, everyone. Once again, I want to thank you for joining this, but my request to each and every one of you who come into attendance, you can see the enormity of the task. You can see the effort that it's going to require for us to really have an impact and close the gap on healthcare, the delivery of healthcare in the African American community. You got an understanding of the problems, and then you also got real life examples of how it's manifested day to day, and right here on the south side of Chicago. My request of you is that you share this information with your friends, your family. This webinar will be put up on our YouTube channel so that you can, for those that were not able to join us today, that they can join us. But I want to encourage all of you to follow this, because as Irshad said, this is not this is not intended to be an event during Black History Month just to hear about a problem. This is intended to be the kickoff to making this a process where our community will come together, inshallah, and deal with assuring that there is quality health care, not only in the African American community, but in all communities of color in Greater Chicago. And the one thing I would add is right now, that CIGC is deeply involved with the resettlement of Afghan refugees, and the issues as they're outlined by Dr. Shabazz and Rilwan Martin, they're the same. So the task is before us, my brothers and sisters. Inshallah, come join us as we, as a community, will fight and bring better health quality in these communities. Finally, I would like to thank very much Dr. Munira A. Curtis and Dr. Constance Shabazz and Rilwan Martins for sharing and taking the time to prepare these informative presentations. We're deeply appreciative of the work and time you've put into it. And inshallah, it has been of great benefit to our community. So with this time, I would now close the program with recitation of Surah Asr. A'udhu billahi minash shaitanir rajim. Bismillah ar-Rahman ar-Rahim. Wal Asr. Inna insana lafi khusr. Illa ladina amanu wal amilu salihat. Wa tawassaw bil haqqi wa tawassaw bis sabr. Assalamu alaikum